Welcome to the Basic Obstetric Ultrasound Training Course for Healthcare Providers. Ultrasound plays an important role in identifying pregnancy-related conditions that put the mother or fetus at risk during delivery. In most low-income countries, there is a shortage of people experienced in performing pregnancy ultrasound. This course was created to train healthcare workers to perform basic pregnancy ultrasound in parts of the world where formal training is not available. The videos, as well as other educational materials, available at tinyurl.com/UW ultrasound, are designed to be used in a 2-week ultrasound course. The hands-on sessions in the trainer's guide are an essential component of this course and must be supervised by an experienced ultrasound practitioner. This is not a comprehensive pregnancy ultrasound course and does not result in an official certification or diploma. After you finish the course and pass the written and practical tests, we strongly recommend you have at least 40 hours of scanning experience with clinical mentoring before you undertake unsupervised scanning. My name is Dr. Christina Adams Waldorf, and I will be narrating this 16th video in our pregnancy ultrasound series. This video will focus on the normal and abnormal growth of the fetus. Please visit our website for access to all of our video and training materials. There are 3 main skills you will learn in this lesson. You will learn how to evaluate for intrauterine growth restriction, or IUGR, on clinical exam, evaluate for IUGR with ultrasound using 3 different indicators, and make appropriate referrals for IUGR. Intrauterine growth restriction is a condition where the fetus simply does not grow as much as it should. A fetus with IUGR has measurements on ultrasound that are less than 90% of fetuses of the same age. Restricted growth puts the baby at higher risk of cesarean delivery, low oxygen level at birth, and even death. Most often, fetal growth slows when blood flow from the mother to the fetus is poor. Several conditions of the mother can impact this blood flow, such as poor nutrition, diabetes, and high blood pressure. Other problems contributing to IUGR include placental abruption, placental previa, an abnormal umbilical cord attachment, or an infection. Sometimes the cause is related to the fetus itself. Multiple fetuses and birth defects may also reduce blood flow to the fetus. The first clue that IUGR might be present comes from your clinical exam and the measurement of fundal height. To measure the fundal height, measure from the top of the mother's uterus to the top of the mother's pubic bone in centimeters. Normally, the fundal height is approximately equal to the gestational age between 20 and 36 weeks within 2 centimeters. Within a few weeks of delivery, the fetus usually drops lower into the pelvis, which can decrease the fundal height and makes fundal height less reliable close to the due date. Here is an illustration that better shows how to measure the fundal height from the top of the pubic bone to the top of the uterus. Use your hand to find the top of the uterus by pressing on the mother's abdomen. For example, if the gestational age established by an early ultrasound is 31 weeks, the fundal height should be approximately 31 centimeters, but normally might range between 29 and 33 centimeters. Measuring fundal height accurately requires practice, and if you do not have a lot of experience, ask another provider with more experience to confirm your measurements. IUGR might be present if the fundal height lags the gestational age by 3 centimeters or more. For example, if the gestational age established by an early ultrasound is 31 weeks, IUGR might be present if the fundal height is 28 centimeters or less. Remember that fundal height is accurate between 20 and 36 weeks and should not be used close to delivery when the fetus normally drops into the pelvis, which decreases fundal height. So what should you do for the patient at 31 weeks who has a fundal height of only 28 centimeters? The answer is ultrasound. There are 3 conditions you can identify with ultrasound that can indicate IUGR. These include oligohydramnios, smaller than expected fetal size, also known as a lag in fetal biometry, and an abnormal biophysical profile, which is a scoring system of fetal well-being. Another method is to use ultrasound to evaluate the characteristics of blood flow through the umbilical artery, but we will not discuss this method in the course. Now we will discuss these first 3 conditions that might indicate IUGR and a high-risk pregnancy. Now let's review our previous lecture. Please ask a volunteer to recall what we might observe on ultrasound with oligohydramnios. Which 2 methods might we use to verify oligohydramnios, and when should we use each method? Please pause the video now to discuss. Recall that with oligohydramnios, you will see little or no amniotic fluid on ultrasound. The fetus will appear crowded. Because of the lack of fluid, the fetal parts are more difficult to see clearly. There are 2 ways to measure oligohydramnios. Use only one of these methods and not both. Before 24 weeks of gestational age, measure the maximum vertical pocket. You should also use this method if there are twins. At 24 weeks and later, measure the amniotic fluid index. A maximum vertical pocket less than 3 centimeters or an amniotic fluid index less than 5 centimeters indicates oligohydramnios. Remember that neither umbilical cord nor fetal parts can be in the vertical path of the calipers. The next ultrasound tool that might indicate IUGR is to measure the fetus and determine the fetal weight. To determine fetal weight, measure the biparietal diameter, head circumference, abdominal circumference, and femur length. This was discussed in a previous lecture. With most machines, the OB software package will calculate the fetal weight from the biparietal diameter, head circumference, abdominal circumference, and femur length. If your machine doesn't have an OB package, you can use a chart to determine weight. Please refer to the table that estimates fetal weight based on abdominal circumference and femur length in the participant handbook on our website. This is how the ultrasound machine might show estimated fetal weight based on biometry measurements. Your screen showing estimated fetal weight may look different than this example. First, notice the gestational age of the patient at the top of the screen in the red box, which is 30 weeks and 2 days based on last menstrual period. This dating was confirmed by an early ultrasound. The red arrows on the left indicate the measurements in centimeters taken by the sonographer for biparietal diameter, head circumference, abdominal circumference, and femur length. Next, we see how the ultrasound machine assigns an estimated gestational age to each of these measurements and an overall estimated fetal weight, or EFW, of 1,560 grams. The red box on the right shows an estimated gestational age for each of the measurements taken. The red box on the left shows the overall estimated fetal weight in grams and also assigns a percentile score to fetal growth, in this case 40%, which is very normal. For a diagnosis of IUGR, fetal growth must be less than the 10th percentile. To summarize, the first component of evaluating for IUGR is to obtain fetal biometry, which means measuring the fetal biparietal diameter, head circumference, abdominal circumference, and femur length. Then, calculate the estimated fetal weight and determine if the fetal weight is normal or abnormal compared to other fetuses at the same gestation. Intrauterine growth restriction is defined if the fetal weight is less than the 10th percentile, which means smaller than 90% of fetuses of the same gestational age. Note that fetal weight estimates are only useful to diagnose IUGR if there is a prior ultrasound to establish her due date. If the gestational age is unknown, a smaller than expected fetal weight may be due to inaccurate menstrual dates. Let's look at an example. Assume we did our first ultrasound on the 1st of March, which determined the gestational age to be 12 weeks. Then, on the 24th of October, we begin to suspect IUGR. The fetus is now 30 weeks based on our first ultrasound. We collect our biometry measurements and estimate the fetal weight to be 1,201 grams. Now we look at our estimated fetal weight chart. Please pause the video to take a moment and find the estimated fetal weight chart in your handbooks or download it from our website. At 30 weeks, the average weight is 1,559 grams, and 90% of fetuses are above 1,294 grams. The EFW of 1,201 grams is below 1,294, so it is abnormal and we would diagnose IUGR. Remember to use the gestational age based on the first ultrasound because it is most accurate and not the second ultrasound. When assessing fetal weight, always begin at the 10th percentile column. Normal fetal weight is equal to or greater than the 10th percentile for gestational age. Suspect IUGR if weight is less than the 10th percentile for gestational age. Let's practice with another example. Assume you have an estimated weight of a fetus at 23 weeks to be 560 grams. Please pause the video now to use your estimated fetal growth chart to determine if this fetus is a normal weight. The answer is that at 23 weeks, 560 grams is above the 10th percentile weight of 471 grams. So this fetus is in the normal weight range for this gestational age. The biophysical profile, or BPP, is another way to assess the overall health of the fetus. In this method, we look at 4 fetal characteristics on ultrasound and score each with 2 points if normal, or 0 points if abnormal. A score less than 6 may indicate fetal stress. A very low score means the fetus is at risk for complications or death. Now please find the biophysical profile score chart in your handbooks. This is a standard scoring chart to help determine fetal well-being. The 4 characteristics to observe with ultrasound are breathing movements, body movements, muscle tone, and amniotic fluid volume. Please pause the video now and take a moment to review the chart in detail. We will demonstrate how to do the BPP in the hands-on sessions. Let's review how you should evaluate for intrauterine growth restriction. The first step is to measure the fundal height during clinical exam. If there is a lag of 3 centimeters or more, go to step 2 and perform an ultrasound. During the ultrasound, evaluate for oligohydramnios, estimate fetal weight, and score the biophysical profile. If oligohydramnios, fetal weight below the 10th percentile, and a biophysical profile less than 6, refer immediately to the hospital. Let's review the key points. A fetus with IUGR is at high risk for complications and death. There are maternal, fetal, and placental causes of IUGR. Ultrasound is the best way to evaluate for IUGR. If ultrasound indicates IUGR, you should refer the mother to the hospital urgently. Questions for review. What is the clinical definition of intrauterine growth restriction? The answer is a fetus that weighs less than 90% of fetuses at that gestational age. On clinical exam, a lag of 3 centimeters or more between fundal height and gestational age. What are the 3 ways to assess for IUGR and its complications using ultrasound? The answer is amniotic fluid index, biometry compared to a previous ultrasound, and biophysical profile. What should you do if you suspect IUGR after an ultrasound exam? The answer is to refer the mother urgently to the hospital for evaluation by an obstetrician. Thank you for your attention and interest in learning pregnancy ultrasound. Please pause this video now to ask your instructor any questions about this course. We thank the following individuals who played a major role in course development: Dr. Robert Nathan, Dr. William Marks, and Nicole Goldsmith, registered sonographer. Many other individuals contributed valuable time and expertise in the instructional design and materials development, including Dr. Christina Adams Waldorf, Dr. Scott Barnhart, Dr. Michael Kawuya, Susan Kingston, and Stacy Lissett. Finally, we wish to thank Dr. William Marks for the use of images from his book, Ultrasound, A Practical Approach, and Jennifer Summers and Jan Hamanishi for graphic design and illustrations. The University of Washington Department of Radiology has trained healthcare workers in pregnancy ultrasound in many parts of the world. If you have questions about this video or course, please contact Dr. Robert Nathan, Dr. William Marks, or Dr. Christina Adams Waldorf. This course was collaboratively developed by the University of Washington Department of Radiology, Obstetrics and Gynecology, and the International Training and Education Center for Health, ITEC. It was made possible through a grant from the GE Foundation. Consano also contributed funding. We are grateful for the video production sponsored by the University of Washington Institute for Simulation and Interprofessional Studies. Please visit our website at tinyurl.com/UW Ultrasound to access all of our training materials. This material is copyrighted. You are permitted to copy, distribute, and post to websites. You are permitted to modify the content to adapt to specific populations and user needs on the condition that you include attribution to the University of Washington and retain any copyright notices and citations and attributions included in the original Basic Obstetric Ultrasound Training for Midwives. The material in this video is provided for information purposes only. The University of Washington Institute for Simulation and Interprofessional Studies does not take responsibility for the accuracy of the content in this video.